We are having 141 login in Slido and 131 in Zoom.
I'm getting message from three teams: Red Locked, Latent, Phoenix. Nirav bhai, if they're in the waiting room, please let them in the Zoom. Red Locked team, Latent team, and Phoenix team. Rose team, ROZ. Rose team.
Sir, team by name, team HR is also not able to log in into Zoom meeting. ಅಯ್ಯೋ, ಏ, ಎಲ್ಲ ನೋಡು.
Nirav bhai, if anybody else is waiting, please let them in.
नहीं नहीं नहीं. Sir, this is three team, sir. We are not able to open the link for the quiz, sir. It is,
Maximum people have opened.
sir.
Please try and retry. We cannot help more than that.
It's not started yet, right? Like no questions have come.
It will start. Everyone should see this page where you will see get ready and your team name. So shall we start?
Yes, sir.
So I think
Yes, sir.
Neera, we can start. We already have 160 users on Slido. So we can start at a 7 2 p.m. Yeah, so first question is
So,
displayed. Now we no more entries into Slido.
nearby shut down the entry in the
It's
Slido.
showing voting closed.
Let them join. If someone by chance logs out and rejoins in Slido, that is okay, I think.
Yes, nearby.
Please start. Nero bhai, please start the quiz.
It is already there.
I am seeing the first question in Slido.
Okay.
So the same thing is seen on the Zoom as well. Hello.
Rad logged, your video is logged. Final warning.
Ma'am, if you can send the quiz wala link once again in the chat box, ma'am. We are totally switched to logged off, ma'am. We need that to log in again.
Ma'am, where to answer these questions? We don't have any platform.
No, sir. We just
program नहीं दिख रहा है.
Where to answer these questions?
You have to answer in the link provided in the chat box. Please, this is the latest link. Click on the link, enter your team name. A new window will open. It is a Slido platform. You have to answer there. These are just for viewing. Quiz is being done on Slido. The link that has been provided in the chat box. Please use that.
We have been repeatedly giving instructions since half an hour, 45 minutes. We have kept up practice sessions. Still, people are having such kind of queries.
भी हुआ है कर दिया.
Okay, we again have a window in new window link pasted in the chat box. Use it again. Attempt on the Slido platform. You will only see.
Down syndrome.
Please don't speak anything loud. Keep your mics closed unless you have an emergency. Otherwise, you will be disqualified.
All mics should be off, muted.
Team Stringence, I can see only one person. Kindly show the other person, please. Okay, great. Brainy Brigade. Red M Esters. Grey White. Octopus. Karthik Priya. I don't remember any team with such name. Gurpreet sir, please note. Hamdard Residents, can you show me your other team member in the video? I can see only one person, Hamdard Residents. Gurpreet sir, please note Hamdard Residents only one team member seen throughout the session.
Shreya and Samarth, your second member is not visible. Are you playing? Are you in the quiz? Shreya and Samarth. In question 11th, please read at imaging sign.
One of the combination is wrongly matched. Imaging sign combination.
A word of unnecessary advice for all teams. Please do attempt the questions. There is no negative marking. I am seeing many teams are not attempting only.
It's coming as voting closed.
It's coming as
voting is closed. Actually, voting is closed.
Voting closed.
Unable to answer this question. Like unable to click on any option.
So is
It is
this
showing
happening for
voting is
everyone?
closed.
It's for everyone.
Okay, so
It is showing as voting closed, sir.
okay, no
So nobody
problem.
could answer.
We will
can log this
continue. We
question
will
again.
continue. Nirav,
Neerav, please check.
okay, so we will just keep in mind this question 29. You continue with
29.
question 30 now.
Sir, previous question is coming. The current question is not there.
Yes, sir. The previous question what we have answered is now there in the screen, in the
Yes,
answering
sir.
screen.
Same thing happening with us also.
The last question we could not answer, and previous question is coming.
same happening.
Question number 31 is in the screen, sir, in the answering screen.
Okay, just wait. Neerav,
Yes, sir, it's back now, sir.
It is showing that the current question it is showing we were not able to vote.
okay.
Okay. We'll take care of 29 and 34th question. Don't worry. Switch on to next question. 29, 4th. Please focus on 35th question.
So we come to the end of this quiz round. All 50 questions are completed. So there was problem with question number 29 and question number 34. So we are going to remove those two questions from the total assessment. And I hope all the teams were able to mark and submit their responses for all the remaining 48 questions. Is it true?
Question number 50.
Excuse me, sir.
Yes.
The last question I did not get the sent option that in order to press the sent option, that option is not showing that.
I think more people have answered the last question, almost
I was
141.
I was constantly refreshing, sir, but it did not came. That the sent clicking of that part.
141 people have answered, including myself, should not be an issue.
I agree for question number 29 and 34, there was some malfunction. So those are eliminated, but remaining questions displayed correctly.
If you have any issues with any other question, it will be your internet connection or device issue, and it shall not be considered.
We were logged into the meeting, but we couldn't see the first four questions.
Sir, we were not able to answer the first 8 questions, sir. We were not even able to log in for the first 8 questions, sir. The slide.
No, this is clearly some problem with your connection, some problem with your internet or software issue. So we proceed with the discussion section part of the quiz today, and I request Nirav to share the presentation for the updated presentation for the discussion for the answers. And I request all the faculty, I hope all of them have joined. And as we follow a particular sequence, which Dr. Nidhi must have already shared, and we will start with the discussion. So Nirav, you can share the answers presentation. So based on the correct answers, all teams will have their scores, but based on multiple parameters, including the correct answer, time, we will have the final ranking. So that is all going to take time, and we will update you with the results in weeks' time. So can we have the next slide?
Also, before we start the discussion, no teams will get their scores, no teams will get their rankings. Only the top 50 teams will be selected, other teams will be eliminated. And we will request the top 50 teams to provide the proof of 3 things. 1, AOCR registration for both team members. 2, permanent life membership for both team, provisional life membership for both team members. And 3, letter from their HODs regarding their joining date to know their current status of residency.
Yes, so till today, the registration for AOCR was not mandatory, but from next round onwards, AOCR registration and other prerequisites, as Dr. Gaurang just mentioned, is very, very important, and otherwise team will not be continued in the quiz. So, Dr. Abhishek Arora, are you there?
Just one small note. A while back, it was mentioned that exam going PGs are not, like, people who have exams in January are not allowed or something like that.
Yes, because you have already had a chance to attempt the last year. So January AOCR final will be there. Pure second year and pure third year only are allowed, as was mentioned in the brochures before.
But so we are.
Please, we can proceed with the discussions.
Yeah, that is a later discussion. So, Dr. Abhishek, you are there?
Yes, sir, I'm here.
Yeah, so you can start. Next slide.
Right.
So, Dr. Abhishek is professor and head at AIMS BV Nagar near Hyderabad. So, Dr. Abhishek, you can proceed with your question. Next slide.
Nirav, please switch on the slide.
Next slide.
Right. So the question which I asked was, the patient came with a complaint of insidious onset, gradually progressive, painless diminution of the vision in the left eye. And it was a very, I would say, easy question, because if you rule out one by one the causes, like optic nerve hypoplasia is not there. The patient had symptoms at a very old age, that is at the age of 50. Optic nerve glioma nowhere is seen. Optic perineuritis is not there. So the correct answer is non-arterial anterior ischemic optic neuropathy. So If you have answered it correctly, congratulations. If not, then read about this particular entity. So it is very classical entity which older patients they come up with single vision loss. So the next slide can be if next is mine. Yeah, so this was a case you can classically see that there is a gout. There are classical imaging features of gout, and when we see these particular crystals, when we do the joint aspirations, then definitely the gout crystals are needle shaped and they are negatively birefringent. This was what was being expected as an answer from you all. Rhomboid shaped crystals are usually seen in pseudo gout. You all must be aware of in CPPD diseases. So the correct answer is needle shaped crystals which are negatively birefringent. So over to the next slide and to the next faculty.
Okay, Dr. Anand, you are there?
Yes, sir, I am there.
So if you can switch on your video. And Nirav, you have to pin the faculty who is presenting.
Hello, good evening.
Yes, yes. Yes, yes. We can see you. Good evening. So you can start. Dr. Anand is professor and head at Datta Mega Medical College at Nagpur. So you can proceed with your questions.
Yes, sir. My first question was really simple. It was name the investigation done. As one can see here, the investigation is quite easy to identify. If at all, you will notice density of the contrast. Density of the contrast, what appears in the bladder is somewhat same as that seen in the pelvic system and ureter. Actually, this patient came with a difficulty in micturition. We had passed the catheter. This is the micturating cystourethrogram. What is the answer? It was done. And this one is a reflex. So what one can see here is a deformed bladder with bladder diverticulum and bilateral grade 4 reflex. So this one is micturating cystourethrogram and not intravenous urogram. Next, please.
Next.
This one is really interesting case. This newborn child, the radiograph of chest and abdomen, the combined radiograph, what you can see here, AP view. If actually someone had the bubbled Down syndrome, it is because of the double bubble appearance, what you had noticed it. Somewhat a quick response was there. However, just pay attention to the other findings as well. This patient, this one is the right side. So this patient had a dextrocardia with cardiomegaly, and he had situs inversus as well. Okay, so this one is a situs inversus with double bubble appearance due to duodenal atresia. If you can count the ribs, there are 11 pairs of rib on either side. So 11 pairs of rib is there. And this one is a Mickey Mouse ear sign with somewhat a winging of scapula, what one can see here in the pelvis. So this one is a Down syndrome. So good response. Next one. This one is it's a little bit tricky. What is not included in the classical triad of this condition? At first, you must diagnose what exactly is this condition. This condition is the prune belly syndrome, as one can see here. And this syndrome is characterized by this triad. That is, we are having absent abdominal wall musculature. That's why such appearance with undescended testicle and the renal dysplasia. Posterior urethral wall is supposed to be, it was blamed like, so being a male and he is having some posterior urethral wall, and because of the posterior urethral wall, there is a somewhat a dilated bladder, over distended bladder, which is causing all these symptoms. So it is not allowing abdominal wall to develop properly and also causing renal dysplasia and extrophy and other changes which might have been seen in these cases as well. So thanks a lot. So this one is a prune belly syndrome. Thanks, sir. Thank you, Gangesh, sir.
Next. Okay, thank you, Dr. Anand. Thank you very much for your valuable contribution. Next is Dr. Vivek Sethia, who is consultant at Jeevan Rekha Super Speciality Hospital in Jaipur. So, Dr. Vivek, you are there?
Yes, sir. I am here, sir. Good evening.
Yeah, good evening. So just to remind everyone that the order of questions in the discussion is different from what it was during the questions round, because we have randomly assigned, and now they are arranged in order accordance to the faculty they which contributed them. So we will continue with the question number 7. The number is mentioned here. So Dr. Vivek.
Sir. So this is a case, a 30-year-old female. She presented with positive UPT and spotting PV. So she came for an ultrasound. So the ultrasound findings were there was a lesion in the left intramural location at the level of left cornu. So we labeled it as interstitial pregnancy. Then an MR was done to confirm. The MR findings are there was a lesion which showed post-contrast enhancement and a prominent vascular flow void was there. So in this case, on ultrasound, the sign which is to be seen is an echogenic line which is seen traversing from the endometrium to the level of lesion. And this case is labeled as interstitial pregnancy, not cornual pregnancy. Cornual pregnancy is labeled in cases of Mullerian anomaly, in unicornuate uterus or bicornuate uterus, but in a morphologically normal uterus, the intramural pregnancy at the level of cornu is labeled as interstitial pregnancy.
Yeah.
Next question.
Next.
So this is a case of 64-year-old chronic alcoholic male with a lesion in right lobe of liver. And we can see the margins of liver are slightly irregular and show nodularity. So the lesion showed arterial phase enhancement with increased enhancement on portal venous phase images and non-peripheral washout on delayed images. So on a background of chronic liver parenchymal disease, this lesion is consistent with HCC, and we will label it as Lyrads 5. Next.
Next.
So this was a case of a young male presented with recurrent CVA, ischemic stroke. And as we can see, this condition, this is moya disease. And what is not true in relation to moya is it is idiopathic. This is non-inflammatory and progressive. So the A answer is incorrect.
Next.
Done. Sir.
Okay. Thank you, Dr. Vivek. Thank you very much.
Thank you.
So next faculty is Dr. Surbi Gupta, who is consultant radiologist at Indraprastha Apollo Hospital in Delhi. Dr. Surbi, you are there?
Yes, sir. Good evening, sir.
Yeah.
So this is
Good
the
evening.
first case. So as you have to identify the condition first, then the treatment. So the condition is typical eclasia cardia on the barium swallow images. We can see the typical bird beak appearance at the G junction. And what are the surgical management options that are given? So I asked for the minimally invasive surgical management. So Heller's with myotomy with fundoplication is an open surgical procedure. The minimally invasive is the per oral endoscopic myotomy, in which the gastroenterologist makes a submucosal incision in the esophagus, goes down all the way up to the G junction, divides the circular muscle fibers over there, and then closes this submucosal tunnel. So this is done by a gastroenterologist, a minimally invasive surgical management per oral endoscopic myotomy. Next one. So first you have to identify the condition and then the mode of inheritance. So I have given you the spine radiographs, the pelvis and the extremity radiographs. So this is a achondroplasia, a rhizomelic kind of a skeletal dysplasia. You can see the posterior scalloping, you can see the champagne glass pelvic inlet, you can see the chevron deformity. But the question was, what is the mode of inheritance? So the mode of inheritance is autosomal dominant. Okay. Next one. Okay, so this was a 17-year-old with a traumatic sports injury. So you have a pelvic radiograph. So you have to know the various landmarks and the various muscles attached to the various structures. So first identify this is the anterior superior iliac spine. This is the anterior inferior iliac spine. And you can see a avulsion fracture. So my question was, what is attached over here to cause the avulsion fracture? So it is the rectus femoris. So on the anterior superior iliac spine, we have the sartorius. In my question, the anterior inferior iliac spine, we have the rectus femoris. Then the glutea are attached to the greater trochanter, and to the lesser are the iliopsoas muscle. So this is rectus femoris avulsion fracture of the antero-inferior iliac spine on the right side. Next one. So this X-ray of an elderly patient with patient in ICU with breathlessness. So as you can see, this radiograph has multiple lines. So that's why my question was based on the lines and tubes positioning over here. So you can clearly see there's a nasogastric tube, there's a right central venous line, and there's an endotracheal tube as well. And you can see that the endotracheal tube is going into the right main bronchus, and it is causing under radiation and this complete whiteout of the left lung. So the correct position, so the malpositioned tube in this is the endotracheal tube, and the correct position of this tube should be at least 5 to 7 centimeters above the tracheal carina. Okay, just be very careful with the option inches, centimeters, so everything can be confusing. This is 5 to 7 centimeters above the tracheal carina. Okay, next question. Okay, so for the barium studies, we have two types of bariums, the microbar suspension and the microbar high density suspension. So the values as well as the units both are important in this question. So for the microbar suspension, we have the 95% weight by volume. And for the high density, we have the 200% weight by volume strength, which is the barium that is used. If the last option, if you see, the values are similar, but this was a volume by volume suspension. Okay, so this is not the one that we use. We use weight by volume strength. So this is 95% and 200% weight by volume for microbar and microbar high density bariums. Okay, next one. Okay. So as you can see, an angle is measured in this lateral radiograph of the ankle. So we have two lines, one joining one and the second point over here, and this one joining the first, third, and the second point over here. The angle formed is the Bowler's angle, which is normally 25 to 40 degrees. And we need to measure this angle in case of calcaneal fractures where it decreases. So value less than 25 degree is an indicator of calcaneal fracture, and the lesser the angle, the more severe becomes the calcaneal fracture. And once you are reading the Bowler's angle for calcaneal injuries, also goes to the Gisane angle, which is also a measure of the severity of the calcaneal injuries. So read about the Gisane angle. The normal value is 120 to 145 degree. Learn the lines of Gisane and Bowler's angle. Okay. Next question. Okay, over to the next
Thank you.
item.
Thank you very much, Dr. Surbi. So, Dr. Reshmi, you are there?
Yes, I am
Dr.
here.
Reshmi is Senior Consultant Radiologist at Anantapuri Hospital and Research Institute at Thiruvananthapuram. Dr. Reshmi?
Yeah, I'm here. Good evening, sir.
Yeah. So you can start with your question.
Yes.
Next slide.
So the question was, what is the diagnosis in this case and what is the expected management? So here you can see air within the portal vein. So you have to differentiate between pneumobilia and portal venous gas. So here from the anatomy, and you can see part of the left portal vein also there opacified. So this is clearly portal venous gas. So if you have a portal venous gas, you have to look for the cause of it. So in adults, so you know that this is an adult CT. So the most important cause is necrosis or ischemia of the bowel. So you have to look for any ischemia or necrosis in the bowel. If you look carefully, you can see the posterior wall of the stomach is non-enhancing and you have air within the wall. So, in the small bowel, don't mistake it for air within the bowel. It's air within the folds. So here the diagnosis is emphysematous gastritis with portal venous gas, and I've included one more question: what is the expected management? Actually, if you know that it's only involving the posterior wall, the patient is stable. The first line of management for emphysematous gastritis is always a conservative management, which is the medical management, which include IV fluids, antibiotics, because it's always caused by gram-negative organisms, and of course, proton pump inhibitors. So the answer is emphysematous gastritis with portal venous gas, and the management is conservative. Next slide. What is the diagnosis in this case and what is the complication seen? So you have a whole body stir here which shows hyperintense signal in the muscles. You can say multiple groups of muscles are involved. So definitely it's a case of myositis. And you see in the HRCT, you see changes of ILD, which is a subpleural patchy consolidations with a atoll sign you can see with parenchymal band. So this is clearly an OP pattern. So myositis with OP pattern, it is definitely a case of dermatomyositis with OP pattern. And I've asked what is the complication that is seen. So if we see the date of the X-rays in the 25th, and that's X-rays which are 3 days apart. So you see alveolar infiltrates in the first X-ray, and which is completely resolved in 3 days. So I'm asking for a complication which completely disappears in 3 days with treatment. So a known complication of dermatomyositis is diffuse alveolar damage, which presents like this, or diffuse alveolar hemorrhage, which usually resolves in 3 days with high dose steroids and ventilation. So the answer is dermatomyositis with OP pattern of ILD with acute onset diffuse alveolar damage. So that's all from my side. Thank you.
Thank you, Dr. Reshmi. Dr. Ranjan Patel.
Good evening to
Dr.
all.
Ranjan Patel is assistant professor at AIMS Bhubaneswar. So, Dr. Ranjan, you can start with your questions.
Am I audible, sir?
Yes.
Yeah. The first question, please.
Next slide. Yes.
This is basically asked ki what is not a contraindication for the procedure seen. So this procedure basically it's a shunt which connects between the portal vein to the IVC or heart, that you call it a transjugular intra-aortic portosystemic shunt. So what it does, it basically diverts the portal flow towards the heart and it increases the cardiac preload. So TIPS is not an indication in presence of congestive heart failure. And again, as it shunts the blood, it increases the risk of hepatic encephalopathy. So TIPS is also not indicated in patients with hepatic encephalopathy. And obviously, if patient is having septic shock, then also TIPS is not indicated. Again, in presence of portal vein thrombosis, presently TIPS itself is an indication in patients with portal vein thrombosis. So here the correct answer is the portal vein thrombosis. This is not a contraindication to TIPS, rather a indication to TIPS. Next. This is the agent that is seen, that is multi-Hans. Multi-Hans is otherwise known as gadobenate diamine. This is basically a hepatobiliary specific MR contrast agents. And if you see all the options, basically this is predominantly excreted by the kidney. Almost 95% of the multi-Hans is excreted by the kidney, whereas only 5% is excreted by the biliary excretion. Whereas the option that is given is 25% of this drug is excreted by bile. Basically, so this is not the 25%, only the 3 to 5% of the drug is excreted. Again, it's a hepatobiliary contrast agent, so it is very useful in the characterization of the focal liver lesion. And like other contrast agent, rarely it can have contrast reaction like iodinated contrast media. Next. This is a spot on diagnosis. Basically, what are the diagnoses after seeing the images? So if you see the non-contrast arterial phase and venous phase images, you can see there is a mass or there is a pathology in the right paratracheal location. And if you see carefully all the images, especially the arterial phase images, you can see it's a arterially enhancing lesions. And in all the 3 phases, it follows the blood pool, basically in non-contrast mimicking the vessels. In the venous phase also, it having same enhancement as the adjacent vessels. And in arterial phase also, arterial or late venous phase, you can see mimicking the vessels. But the important clue is, if you see this third images, you can see there is a aneurysmal dilatation of this vascular structure, which is having direct communication with the SVC. And again, there is a notch which is going along the course of the azygos vein. So this is basically a azygos arch aneurysm, not a paraganglioma, aortic aneurysm, or Castleman disease. So the correct answer is azygos arch aneurysm. Next.
Next.
This is constellation of findings, and you have to mark the correct syndrome. So let's look at the images. So this is the T2, T1, again T2 fat set coronal and T2 coronal images. And apart from this is a right ovarian mass, it is seen in the all lesions. Apart from that, if you see the uterus, it's a bicornuate uterus basically. And if you see the third images, then again there is a bicornuate uterus, and also there is dilatation of the vaginal cavity with collection of fluid within the vaginal cavity. So this is basically obstructed hemivagina with the hematoculpus. And in the fourth image, there is absence of the right kidney. So in MRKH syndrome, the uterus will be absent. So in this case, uterus is absent, then it's not the right answer. Sewer jumps is not related to genitourinary system. It is basically a lung-related disease. Jenner syndrome is again, it's a Wolffian duct disease, and it is seen in male patients. This is analogous to the Overa syndrome. Overa syndrome is basically obstructed hemivagina, bicornuate uterus with renal agenesis. So this is Overa syndrome, and the counterpart in male is the Jenner syndrome, which is associated with some anal vesicle cyst and ejaculatory duct obstruction. That's all about my part. Thank you all.
Okay, thank you very much, Dr. Ranjan.
Thank you,
Dr.
sir.
Hema Chaudhary. Dr. Hema Chaudhary, you are here?
Yes, sir. I'm here. Good evening, sir.
Yeah, Dr. Hema is senior consultant at Max Super Specialty Hospital in Noida. So, Dr. Hema, you can start with your question.
Sure, sir.
Yes.
So this is a clear-cut spotter, which is showing an osseous lesion with epicenter in the left posterior ethmoid ear cells. So that's a clear-cut case of the ossifying fibroma. The closed ED comes the exostosis, but in that case, the medullary cavity extending from the parent bone. So, and this is ossifying, so that cannot be non-ossifying fibroma, and this is, the density doesn't match with the rhinolith. So that's a clear-cut case of the ossifying fibroma. Next case. So in this case, there is a iso-enhancing lesion in the left lobe of the liver, which is showing a scar. And in the delayed MRI scan on DSA, it is enhancing and it is taking the uptake on the sulfur colloid SPECT. So this finding which matches with the focal nodular hyperplasia. In the closed ED comes the fibrolamellar hepatocellular carcinoma, but there will be a heterogeneous and that will not take uptake on the sulfur colloid SPECT. In this, hepatic adenoma will take the uptake, but that will not show the scar. And the hepatic hemangioma, everybody knows that there is a peripheral nodular enhancement. So that's from my side. Over to the next faculty.
Well, thank you, Dr. Hema. Dr. Stenzin,
Good
you
evening,
are
sir.
here?
Yes, I am here.
Dr. Stenzin is faculty at AIIMS New Delhi. So, Dr. Stenzin.
Yes, sir. Thank you. Okay, we'll start with the first of my cases. First of all, about the diagnosis.
Little louder, little louder.
Okay, sir. So am I audible now better?
Yes, yes.
Okay. So first of all, in the two images that I've shown, we can see that there is basal predominance and peripheral predominance of mainly fibrosis, resulting in the formation of honeycombing. So there's no doubt that it's an ILD and it's a UIP pattern. And in the question, I've said which of the diseases it is most likely. So because it's a MCQ, so we have to think of rheumatoid arthritis as the answer, because that is the most common pattern of involvement when it comes to ILD involvement. Unlike in Sjogren disease and scleroderma, we see more of NSIP pattern of involvement. Then rarely we can see UIP as well, or LIP pattern. In systemic lupus erythematosus, we usually do not see an ILD pattern as such unless there's an overlap syndrome going on, more of a pleuritis, thromboembolism, those kind of manifestations are expected. So that is why the answer is rheumatoid arthritis. Next question. Okay, first of all, about the diagnosis, we can see in the non-fat SAT and the single axial fat suppressed image, there's a lot of proliferation of the nerve fibrils. And we can see in the carpal tunnel region, the median nerve, where we expect to see the median nerve, it is significantly bulky. And each of these nerve fascicles are also hypointense and bulky. And the surrounding mature fat proliferation is visible, which is seen to be suppressed on the fat suppressed. So this is a case of fibrolipomatous hamartoma. And of course, it's a benign condition. The answer is B, because it is not, ulnar nerve is not the most common site. It is most commonly seen in the median nerve. And because there is proliferation of fat in the fibrous component in the nerve, we can remember that there's proliferation of other mesenchymal tissue also, specifically in the areas that are supplied by the nerve. So it is usually associated with this macrodystrophy of the digits or limb hypertrophy. So it is associated with clipal tenunae and macrodystrophy of the digits. So just remember, most common site is median nerve. Next. Okay, so this question, first of all, you have to identify the pattern of enhancement, the shape of the mass that you're seeing. So liver is at its normal place. Just below that, you can see the gastric fluid containing the stomach, and below that you can see the lump which the patient feels. So we can see the splenic vein clearly entering into it. The shape of it is like comma shaped homogeneous enhancement and appearance of the spleen. So wandering spleen is nothing but when the spleen is not seen in the left upper quadrant where you expect to see it, and instead you see it either lower down in the abdomen or in the pelvis. Importance of it is that it can undergo torsion. So you have to look for changes suggestive of infarct within it. So it is, if you go to the other options, it is not a hepatic mass. We can clearly see the liver margin separate from it. It's not a mesenteric cyst. The stomach can be confused with a mesenteric cyst, but it will not, this is not the site where you expect to see. Also, you can see in the third image, there's some debris also from the stomach contents. Then other option is hepatic mass we have ruled out, mesenteric, and lymphoma. Lymphoma, you do not see it as a separate mass like this. We'll expect it to be in the retroperitoneum around the aortic and the IVC. Next question.
Next. Yeah.
Yes. Okay. So next is this case. Okay. So some of these terms I've just put in to confuse, although this has got nothing to do with each other. So the answer is Lemel syndrome. We can see in the image, and it also correlating with the history. We know that the patient has jaundice, and because the direct bilirubin is raised, so it's an obstructive jaundice. So we now have to see what is the site or the cause of the jaundice. So if you see, you can see in the second part of the duodenum, there's an outpouching which is containing air along the medial aspect of the second part. So this is a duodenal diverticulum, and because the CBD is dilated and the patient has symptoms, this is Lemel syndrome, which is obstructive jaundice caused by duodenal diverticulum. So duodenal diverticulum otherwise can be seen in asymptomatic patients also, which we see as an incidental finding, but when it causes symptoms, then it's known as Lemel syndrome. And because the PET also said that there was no abnormal uptake, we can rule out mass in this. Coming to the other options, Bouvret is nothing but gastric outlet obstruction, which is secondary to an impacted gallstone in the pylorus or in the proximal duodenum. Limere, which sounds very similar, is again a completely unrelated process where there is some sort of an oropharyngeal infection, and that results in IgV thrombophlebitis, and there can be manifestation in the form of septic embolism, septic arthritis, etc. Mirzi, again, everybody knows it's just obstructive jaundice because of a impacted calculus in the cystic duct or the GB neck. Okay, done, sir.
Okay. Thank you. Thank you very much. Next. Yes, Dr. Sandeep Malla, you are here.
Yes, sir, I am here, sir.
So Dr. Sandeep Malla is consultant and assistant professor at Amrita Hospital in Faridabad. Dr. Sandeep, you can start.
Good evening, sir. Good evening, everyone.
Good evening.
My slide.
Next slide.
Yeah, so this is basically an image. If you can see that black arrow is pointing at a dark structure which appears to be a contrast filled structure. So this basically I have asked which catheter is it. So it's a catheter. So it is a balloon catheter. So if you can see that cylindrical sort of structure that we can see, it is an inflated balloon. So balloon catheters are those catheters which are used to open up structures. It can be a vein, artery, lymphatic duct. So anywhere these are used, these are basically catheters with a balloon implanted in them, and this helps in opening up structures. And the other catheters includes infusion catheter that are used to infuse any thrombolytic or anything. Diagnostic catheters are used for taking diagnostic runs, and guiding catheter is sometimes used to guide a diagnostic catheter for better stability. So this is basically a balloon catheter with contrast, diluted contrast filled in the balloon.
Next.
Thank you, sir.
Thank you. Thank you very much. Dr. Nitin. Dr. Nitin, you are there?
Yes, sir. I'm there.
So Dr. Nitin Gupta is consultant radiologist at Bhagirathi Niyoti Hospital in Kolkata, and he is a seasoned quiz master, and I have seen him conducting quiz in the past as well with IRIA. So Dr. Nitin, you can start.
Thank you, sir. Yeah.
Slides, please.
Next.
Slide, please.
Yeah, so this was a no-brainer because DWM is the odd one out. So we can see easily, we can see a myelomeningocele and posterior fossa obliteration. All these are spectrum of Arnold-Chiari. So answer is DWM, the odd one out. DWM, we see the posterior fossa cyst. So move to the next question, please. Yeah, so all the following are correct about the disease in the image except. So see, again, the diagnosis is very easy. We can see cardiac rhabdomyomas, tubers, and some sort of cortical dysplasia. So the diagnosis is tuberous sclerosis. And again, here we know that it has autosomal dominant inheritance. Cardiac rhabdomyomas, we know that it is part of it, but we also need to know that during pregnancy they grow in the size and they are largest at birth. After that, they regress. So the odd one out again, the genes TSC1 and TSC2, it's like just opposite 9 and 16 rather than 16 and 9. And rest all are the part of this tuberous sclerosis complex. Next slide, please. So there are a couple of images about the MCDA twins of 12 week 4 days. All of us can make out easily that there is a anterior abdominal wall defect and something is protruding. So we can see that I've given you a color image also, Doppler image. We can see the cord insertion on the sac. So that is highly diagnostic of omphalocele. Gastrochiasis, we don't see on the sac. It is usually on the side. And physiological herniation, usually we don't see till 12 weeks. Again, umbilical hernia, we don't see this cord on the sac. Next one. So, I've asked for the name of the technique and needle used. So easily we can rule out that this is not the fetal reduction because the needle is in the placenta, and this is trans cervical CVS. There we use a special 16G olive tip cannula because that is blunt on the front side, and normally Chiba is sharp beveled edge. So we don't use for transcervical CVS. We have a special cannula, olive tip 16G cannula. So this is a transcervical CVS. That's it from my side, I believe. I don't think any more questions
Thank you
are there.
very much.
Thank you, sir. Thank you.
Very much. Dr. Sunita, you are there?
Yes, I am there.
So Dr. Sunita is additional professor at JIPMER Pondicherry. So Dr. Sunita, you can start your question.
Yeah.
Yes.
Okay. So my first question was, this is an antenatal ultrasound at 34 weeks. So we have, if you look at the second image, there is a cystic structure, anechoic structure, and on color Doppler image, you can see a red and blue. So the diagnosis here is an umbilical vein varix. So the color Doppler, what is shown here is a yin-yang sign where to and fro flow in a dilated umbilical vein. So the diagnostic criteria for diagnosing an umbilical vein varix is either the absolute diameter is more than 9 mm, or if you take a ratio of the dilated portion to the distal normal segment, it should be more than 50%. So the other differentials can be ruled out. The fetal choledochal cyst, because it is showing color flow, so it's a vascular structure. Dilated ductus venosus, it is not the location of the ductus venosus, and two-vessel umbilical cord also. The umbilical cord entry into the abdomen is a little lower around the sides of the urinary bladder. So we can diagnose an umbilical vein varix from this picture. Next slide, please. So this is the diagnosis here is a gynecomastia in a male patient. So how do you diagnose this? First, we will look at the MRI images. Please look at the T1 weighted image. So bilaterally in the breast, you can see a hypo-intense structure just beneath the nipple. So there are some speculations or linear striations extending into the posteriorly located fat tissue. So this is a dendritic type of gynecomastia. This person was a young male who was a sports person. He gives a history of using anabolic steroids. So that is
a risk factor for developing gynecomastia. And so mostly the gynecomastias are, it can be unilateral or it can be bilateral, but asymmetrical. So here the left lesion is more pronounced compared to the right side. And in the diffusion restriction, you can see there is no restricted diffusion. Though it is appearing bright in DWI, there is no restriction in the ADC. It's appearing bright in ADC also. And in the post-contrast image, though the nodular structure is enhancing slightly, the curve is, even though initially there is a rapid enhancement, then it is just continuing to enhance. So it's a type 1 curve. There is no plateauing, there is no washout. So it's not looking like a BIRATS 5 or probably malignancy. And if you come back to the ultrasound image, it is having the typical pattern of a glandular tissue. So we can diagnose gynecomastia in a male patient from this. Thank you, sir. That's all from my side.
Thank you very much, Dr. Sangeeta. Thank you. Dr. Divasha is there?
No, I think she's not joined. I'll take up the questions.
Yeah. Dr. Ankur will help us with the discussion of her cases. So we have faculty from different parts of the country, from north to south and east to west. And after collecting the cases from all the faculty, we have added few cases which we will, to balance the system, and few areas which were not covered. So as Dr. Deva submitted the question. So Dr. Ankur, you can proceed with this.
This was the mammogram image as well as ultrasound image of a 70-year female with painless lump in left breast. And BIRATS and diagnosis based on these images is mucinous carcinoma with BIRATS 5. So C is the correct answer. Next slide, please. A 35-year male with difficulty in swallowing. And you can see there is a small calculus which is at the opening of the duct, sublingual duct, and there is inflamed sublingual gland. So this is acute right sublingual silidinitis with prominent lingual artery flow void on the right side in the floor of mouth. So again, C is the correct answer. That is an impacted calculus. Next, please. This was a very classical image. You can see the part of cricoid cartilage which is normal and the part of cricoid is expanded on PET-CT scan without significant FDG uptake, and on MR it is showing significant hyperintense signals, and that is a characteristic of chondroid lesion, and this was the chondrosarcoma of cricoid cartilage. Next, please.
So I am very thankful to Dr. Ankur and Dr. Nidhi also to look at all the cases, because we collected a lot of cases, but then we have to look and validate the cases and make them keep a correct balance of organ systems and other areas. So accordingly, they added few questions which were not included, with areas which were not covered. So these are additional miscellaneous questions. So Dr. Ankur will discuss this quickly.
So this was the different osteonecrosis, and then their eponyms. Like we know that femoral head osteonecrosis in pediatric age group, it is termed as Lake-Cow-Perthes disease. Lunate, it is Kienbock. For vertebral body, it is Kummel's disease. So for scaphoid, the osteonecrosis of scaphoid is known as the Pleaser's disease. So D is the correct answer. Next, please. The muscle showing fatty atrophy in given image. So this is a very known condition where there is a chronic denervation of the Baxter's nerve, which affects the abductor digiti minimi muscle, and there is fatty atrophy of abductor digiti minimi, and that is Baxter's nerve, or the name of that nerve is the inferior calcaneal nerve, which is a branch of lateral plantar nerve. So the inferior calcaneal nerve is the correct answer, A. Next, please. Which structure is clearly abnormal? So this is a shoulder where you can see the subscapularis tendon is seen in continuity, maybe a little bright, but that is just partial volume part. The head of the humerus is okay, the glenoid labrum is okay, but if you look at the biceps tendon, the long head of biceps tendon, instead of being in bicipital groove, it is completely dislocated. When there is extra-articular dislocation of the biceps tendon, you can see it just anterior to the subscapularis tendon. So the long head of biceps is the structure which is definitely abnormal in this image. Next, please. What is true for the condition which is given, which is shown in the above image? If you can appreciate, there is a focal edema with fluid collection deep to the iliotibial band, and that is the condition known as the iliotibial band friction syndrome. So what is true? It is not commonly associated with ACL tear. It is not a variety of denervation. It does not cause more pain while climbing stairs, that is with chondromalacia patella. But this is commonly seen in runners, particularly the amateur runners. So this is a condition which you will see in many patients who give history of recent long distance running, and then they present with this edema deep to the iliotibial band. Next, please. Okay, sir, you can take this, I think, remaining questions.
So this question is about the configuration of the CT gantry. So you can see multiple detectors seen along the lower part of the gantry, while a single CT tube on the top. So this is clearly a multi-detector CT. So resident need to know inside out of the machine. So this is one example what they should know. Next slide. Next question. So cases from the cookie jar is the manuscript category in radiographics. So this is named after the editor-in-chief, Dr. Christine Minias. And everyone should know about this because this has very good worked up cases where radiology pathology correlation is often there. So this is a category in radiographics journal of RSNA, cases from the cookie jar. Next. Identify the marked surgical landmark in fist. The arrows are seen on both sides, which is showing anterior ethmoid notch, which carries the anterior ethmoidal artery. And this is a very important surgical landmark because of its close relation to the ethmoid air cells. And accordingly, there is a risk of rupture or injury to the anterior ethmoidal artery during the procedure of FES. So this should always be localized and should be conveyed in the report about the relation with the ethmoid air cells. Next. So this is a combination, 4 different combinations of imaging sign, and the actual image is shown. So option A, B, C, and D. A is the stacked coin appearance in ileocolic interception. That is correct. B is a sandwich sign in lymphoma, non-casitating nodes, and the vessel in the center. D is a accordion sign, atoll sign. Atoll is an island which you can see. This is seen in a reverse halo appearance on HRCT in fungal infection, while C is a pear-shaped bladder. So it is apple is not the correct thing. It is a pear-shaped bladder. So this the wrongly matched combination is C. So C is the correct answer. Next. So everyone, the resident should be aware about MR guided HIFU is now coming up in a big way for a lot of neurologic applications, including tremors, OCDs, and Parkinson's disease. Ophthalmoplegic migraine is not a approved indication for this. So as a resident, you need to be aware about the clinical applications of imaging, basic physics, contrast, uh, clinical imaging science, and apart from that, lot of things about recent advances also. This is true for MD, DNB, DMRD exams also, and is for the quiz, this particular quiz also. Next. So genicular artery embolization is a newly evolving treatment modality by interventional radiology for osteoarthritis, which causes targeted embolization of cartilage neovessels. It is non-surgical option for mild to moderate OA only, and skin discoloration is supposed to be an important side effect. It leads to significant clinical relief, but usually the changes on MRI are not reverted back. So option C is the correct answer for this question, because that is not the correct thing. MRI changes doesn't revert. Next question. So again, residents should be very clear about their thesis, and the thesis and research protocols. Biostatistics is something important in our curriculum in radiology. So this is a graph which shows 2 studies, study A and B, and what should be the minimum study statistical power for the study to be acceptable. So this is very clear, clearly accepted that study should have at least 80% statistical power for its clinical relevance. So option is C. Next. Photon counting CT is another new application in the field of CT. And now new age scanners are not about the speed. New age scanner is not following the same number of scans per minute. Now they are into energy-based scanners. So photon counting CT or PCCT is the new advancement in CT, which works on the principle of single step processing and conversion from direct X-rays to electric signal. So that is the option D is known fact about the PCCT. It definitely helps in metal implant imaging in a better way because susceptibility artifacts are low, and it allows simultaneous acquisition of high spatial resolution and multi-energy images. So B, C, and D are correct statements, while A is not correct because it involves uniform weighing of the photons. So A is the correct answer for this question. Next. Okay, 24 weeks gestation, and though X-rays or CT is usually avoided in patients who are pregnant, but at times they are required according to risk-benefit analysis. And in this example, CT pulmonary angiography was required in a pregnancy patient for the diagnosis of pulmonary embolism. So CT pulmonary angiography is a relative contraindication. It is not an absolute contraindication, and in those cases, internal radiation shielding is possible because the mother is asked to drink barium sulfate solution, and the bowel, which is filled with barium sulfate, acts as a shield between the radiation field in the chest and the fetus in the pelvis. So this is an internal radiation shielding, and barium sulfate solution is the solution which is used where mother is asked to drink this solution, and the scan is done for the pulmonary embolism. CTPA can be done during pregnancy as well when it is required. So correct option is option B. Next. So which of the following is not included in the Mayo Clinic diagnostic criteria? So this example, CCT axial image through the pancreas clearly shows a sausage-shaped pancreas with blunting of the tail because of autoimmune pancreatitis. But Mayo Clinic diagnostic criteria involves set criteria, which includes histopathology changes like periductal lymphoplasmacytic infiltrates, serum IgG4 levels of more than 180, and response to steroid therapy. So A, C, and D are indeed part of Mayo Clinic diagnostic criteria, while sausage-shaped pancreas with early enhancement is not a part. Rather, it shows a slight delayed enhancement. So correct answer for this question is option B. Next. Okay, thank you. So we come to the end of this discussion session. And if there are any, Gaurang, Dr. Gurpreet?
I think, sir, this went very well, and most have answered most of the questions through the new international quizzing platform. If anybody has faced an issue, obviously it is because of their internet connectivity or not logging on time. And especially to help the students, we had kept a trial round on Thursday, which have helped them immensely. I would really like to take a moment and thank Nitin sir, Nidhi ma'am, Ankur Shah sir, Gurpreet sir, and the entire team of RX events. Repeated reviewing and re-reviewing of questions, reviewing of the platform, and making sure that students don't face any issues. They have taken time out every day of their busy schedule since last 2 weeks, and continuously they are after making this event, especially the elimination round, to a grand success. I would also take this opportunity to thank Dr. Murli sir, Dr. Andrasu sir, and Amarnath sir, who have guided us. We had options of 2, 3 different platforms, but after much discussion and trying and testing, we have come down to Slido, and I think it has worked very well. Everybody would agree with me.
Yes.
I think I would have a quick feedback from Ankur sir and Nidhi ma'am and Gurpreet sir regarding today's this thing.
Nidhi, you first.
So Dr. Nidhi has played a very important role in, even Dr. Ankur and Dr. Nidhi, they have reviewed hundreds of questions and finalized top 50 questions and then made it in a presentable format. So that made things easier for the rest of us. Thank you.
But first of all, thank you so much to all the faculty. I know it was a great effort to send all the questions. It was very difficult for us to choose the right questions. It was never like which question was good or which question was not good, but it was about keeping the questions from all the modalities, like from CT, MRI, ultrasound, and as well as from all the systems in the body. That was
Plus,
the
we have to
main
balance the level of difficulty as well. So that
level of
was the
difficulty as well,
important
right?
challenge. And faculty has given few very good questions, but we have to select very few questions out of what we have given.
Exactly. And I hope we did pretty well as far as technology is concerned. There was no hitch today. There were only hitch in 2 questions. And the answers were pretty clear to all the students, I hope. And wish you all the best for the next round. Thank you.
Hello, excuse me, sir.
Yes.
Yes.
Sir, this is regarding one doubt that exam going radiology PGs are not allowed for the quiz or something.
We will discuss this among ourselves and let you know, because that is a policy decision. We cannot discuss it right now. Dr. Ankur, you were saying something.
No, this was just thank you all faculties for taking time out to give the excellent questions. Thank you to all the participants for participating and for bearing with us. We had some issues and we were also extremely disappointed after the first round, because after working so hard, you all facing some issue in answering the question, it was very painful for us also. So this entire couple of weeks we have tried very hard so that the things go smoothly. Nitin sir is always there to guide us for each and everything, for every small step. Dr. Nidhi is worked very hard to combine all the questions. Dr. Gaurang, Dr. Gurpreet, they are all are, and the team with Doctor, they all have helped for this platform and all. And if you have found these questions a little difficult, maybe we had to keep them a little more tricky, because you all are so smart and so much efficient that keeping easy questions means you all would have scored more than 80-90%. So unfortunately, we had to keep some tricky questions as well. And I'm sure in spite of that, you all have done very well. All the best wishes. Dr. Gurpreet?
Yes, sir. Congratulations to all for completing this yet another round of 50 questions second elimination round. Now we will proceed to the third event, in which we'll select around 50 or so teams from this round. And numbers and ranks will not be displayed. We'll just create a new group for all the selected participants. And as Dr. Gaurang had told before, this time the selection criteria and the requisites for those participants have been outlined by Dr. Gaurang, and we'll do that again in the group. So AOCR registration and provisional life membership and duration of residency. These 3 pointers will have to be taken care of by all the 50 teams, and then they will be able to proceed ahead. And
Yes, sorry, please continue.
yes.
Sorry.
Yes. And I know this was a very tricky and tough round, and Dr. Nitin and Dr. Nidhi ma'am have done, and Dr. Ankur sir have done a wonderful job. And we hope to continue the trend in the next rounds.
Thank you, Gurpreet sir. Sorry for interrupting in between.
No.
Just wanted to reiterate, as I said, we will be requiring the 3 things from the teams who will be qualified, and I will contact them personally on WhatsApp. I think everybody, now we have the numbers on WhatsApp. So one will be the AOCR registration of those teams. So if you have not registered, it is a good time to register for everybody. And if you think you will be selected in the top 50, please do so, because the dates are running out.
No, rather it is important to register today, because the rates will go up after 8th of December. So today is the right time.
Yes,
if
and
you have done,
AOCR
you have done pretty well in the quiz, register before the results.
Exactly. And anyways, it's a very good conference to attend in the first place. If you are selected or not selected, it is going to be a big event, and all international people are coming. In any case, it will be a win-win situation for all. So please do register, make use of today's time before 12 in the midnight. Second would be the provisional life membership of IRIA. Kindly keep your proofs ready. And the third would be the allotment order. We would require your allotment order, not the HOD's letter. I'm sorry. Let me be very clear once again. The allotment order would be required. Based on that, the decision will be taken. All the best, and we'll come out with the results pretty soon. And the entire process of selecting those top 50 teams will be finished by the next Sunday. So please keep calm and keep on reading radiology, and happy quizzing to all.
Yeah, one more thing is, many thanks to the IT team because they have also worked very hard to make that this event goes without any technical glitches. So thank you very much, Nirav and Hardik. Thank you.
Thank you, Nirav bhai, Hardik bhai. Goodbye, everybody. Have a great Sunday night. Bye bye.
Thank you.
Thanks
Thank
and
you
good.
very much.